Good morning, ladies and gentlemen. It's an enormous pleasure to welcome you all here today. We're expecting a very big turnout, in fact, much more than I expected when I set off planning this. I've got a couple of announcements before we start. First of all, could you make sure that your cell phone is switched off, please, so it doesn't interrupt, like that. I want to encourage you to have a look at all the posters we have outside. A lot of people work quite hard on those, and I think they're quite interesting, so you might like to wander around in the breaks and have a look. And the third thing I'd like to mention is the 1-minute interviews. During lunchtime between 1 p.m. and 2, anybody who likes is invited to go up and speak. We've got a room right at the end of the hall there. They just speak to a camera, basically, for 60 seconds, tell their story, give some advice to new patients, share something, share experiences, and they'll all be put up on the website as sort of little vignettes. So if you'd like to do that, please go along at lunchtime. And of course, everybody has to sign a HIPAA form, absolutely everybody, because even if we just take a photograph and you happen to be in it, for MD Anderson's sake, everybody has to have signed, because that means that they're off the hook and everything's legal. Okay, so I'd like to formally welcome you on behalf of GIST Support International, Dr. Jonathan Trent here, to this, the second GIST Summit to be held at MD Anderson. It's a great pleasure to say that due to the enthusiasm and determination of GIST patients, we have 120 patients and their friends present, or there will be during the day, which with speakers and staff means that nearly 140 people will be here today. Last year's event, we had a combined audience of, combined attendance, I should say, of 90. So this year is a 50% increase on last year. In many ways, GIST is an unknown cancer. Many patients struggle to get accurate diagnoses, as it's often not only fairly symptomless until advanced, but also so rare that it's not a diagnosis that springs to mind to most doctors in the community. Doctors in the community are likely to see one case at most in the whole of their working lives. But if GIST patients are rare, it follows that GIST experts are even rarer. This has led patients desperate for accurate and up-to-date information about their disease or their treatments to turn to the internet, to meet others with GIST, to find out more about their disease, and to find out where to get expert treatment. GIST Support International is a patient advocate group founded to educate and support patients with GIST by motivated patients and caregivers. We're all volunteers. GIST Support International has over 1,400 subscribers on our adult and paediatric listservs. We host a high-traffic encyclopedic website, a Wikipedia full of practical information to which we've all contributed, and we offer financial assistance to needy patients to defray the cost of travelling to see a GIST expert. We're also most pleased to announce the publication of a booklet by Drs. Lazar and Hornick and Jolie Royster, our science coordinator, which is titled Understand Your Pathology Report, which is available here today. And I collected it yesterday from the printer, so this really is hot off the press. I believe the enthusiastic turnout today shows that we're in the vanguard of a universal movement for patients to educate themselves and to take an active part in decisions concerning their treatment. And the medical profession has risen to this challenge magnificently, supporting patient advocacy and educating patients at events such as today's. And in Europe, patient advocate groups are now represented on national and international decision-making bodies such as ESMO. Dr. Trent has been central to supporting this move to empower patients with information. He's played a major role in the evolution of this summit today since the very first small meeting that we in GIST Support International held in Houston here in 2008. He volunteered to come and talk to a small group of us at that meeting, and when asked to come to the 2009 meeting last year, he suggested bringing some of his colleagues to talk along as well. And so it grew. Many of us here today know Dr. Trent well already, but for those from further afield, he is Associate Professor of Sarcoma, Medical Oncology at MD Anderson Cancer Center. His clinical, translational, and laboratory activities revolve around caring for GIST patients while developing new therapies and understanding the biology of GIST. And he also actively supports many patient advocate activities such as this one here today. So I would like you all to welcome Dr. Trent, who's going to open the proceedings with an introduction to GIST.
thank you for the kind introduction, Barbara. And you know, I'm just going to keep this brief because we're running a little behind, but Barbara and Ginger and Marina and the whole GSI gang have put a lot of work and effort into this conference. So before we begin, I'd also like you guys to give a hand of thanks to Barbara and the gang. I mean, this is really an amazing conference, full of information for an extremely rare disease. And for me, as a physician treating patients with this disease, it's it gives me goosebumps and is motivating for me to work harder to find a cure for GIST. And so I also wanted to just clarify one issue about the very first GSI meeting here in Houston. There was maybe 20 or 30 people at it, and Barbara invited me over, and it was in like a club room, and they grilled me with questions for answers for about 3 hours. So I said, Barbara, I can't do this again. We're going to have to call in some backup. I need a consult. So then we decided to expand to additional speakers who are really experts in their individual aspects of GIST and know much more than I do about their areas. So with that said, I'll go ahead and get started. And this session is going to be mostly background information on GIST, not a lot of newer information. That'll come later. So GI stromal tumor is the most common GI sarcoma. So it's the most common sarcoma that occurs in the GI tract, and it's probably one of the most common sarcomas. And although sarcomas are a rare disease, there are maybe 15 or 20,000 cases per year in the U.S., and a large portion of those end up being GISTs. It comprises about 0.2% of all GI tumors, but 80% of all tumors in the GI tract that are sarcomas. And the incidence is right around the age of 50. There's a similar male to female incidence, and many of these are misclassified as other tumors. And one of the big problems, particularly with pathologists who don't see a lot of these, is in the appropriate classification. And Dr. Wong will talk about this later today. And the clinical presentation for patients with this disease is highly variable. So when a patient gets their first symptom, it's really driven by where the tumor is arising from. So these GISTs can arise anywhere in the GI tract, all the way from the esophagus to the rectum. And that site of the tumor will often determine what symptoms the patient has. If they have a GIST arising in the esophagus, they may have a hard time swallowing. Often in the stomach or small intestine, they may have bleeding. They may have a gastrointestinal bleed or an ulcer type situation. If the tumor's arising lower down in the rectum, they may have obstruction and constipation that is really, really severe. But many patients are not found to have any symptoms at all. In fact, their GIST is found incidentally. So this is the magnitude of the problem in the 90s and prior with GI stromal tumor. And this is, I'm going to show a few of these today, but it's basically it's called a Kaplan-Meier analysis. And on this side, and this is data from hundreds to nearly thousands of patients over time. And on this axis is the percent of patients who are living, and across this axis is time. And so in the historical setting, if you look back prior to the 90s, half of the patients with GI stromal tumor had died of their disease by about a year. In other databases, it had happened even before a year, around 9 months in the EORTC database. And so this was a very bad cancer to have because there was no treatment. And this table just puts together a number of standard therapies and clinical trials that were used to to try to treat patients with GIST. And so these patients, we knew that standard chemotherapy didn't work, so the physicians taking care of GIST patients were trying new things all the time. And the column labeled partial response means some small shrinkage of the tumor. And you can see that that's highly unlikely. In fact, it's at best around 7% of the time a patient's tumor would shrink a little bit with all of these different chemotherapies. And a lot of these are aggressive chemotherapies with hair falling out and nausea and lots of problems like that. So this is what was tried historically, and you can see that there was really nothing that was very effective at all. So just because of the frustration of the medical and the research community, investigators in clinical medicine, in biology, and pathology all got together in different parts of the world and worked to solve this problem of GI stromal tumor. And they identified that GIST shared several characteristics with the interstitial cell of Cajal. And this is the cell that is in the GI tract, again, anywhere from the esophagus to the rectum, and it makes up the neural network that's responsible for helping with digestion, the motility of digestion. And so this particular cell, the interstitial cell of Cajal, is found in the same location as where GI stromal tumors arise. It's found to express some proteins on the surface that are identical to GI stromal tumors. And so it's thought that this interstitial cell of Cajal is the cell or in the lineage of cells that give rise to GI stromal tumor. Now, when GI stromal tumors arise from this normal cell, this happens because of mutations in genes within the DNA. So a normal cell turns into a cancer cell because of these mutations. Well, in GI stromal tumor, the gene that is most commonly mutated that turns a normal cell into a cancer cell is called KIT, K-I-T. And it's found in about 95% of GISTs. So KIT is sufficient when it gets a mutation to turn a normal cell into a cancer cell. And then that cancer cell divides from 1 into 2, 2 into 4, 4 into 8, 16 exponentially. And this whole process is driven by these mutations. The most common site of mutation we call exon 11. It's also called the juxtamembrane domain. If you look at this cartoon, this is the plasma membrane of the tumor cell. And just inside of the tumor cell is the juxtamembrane domain, and it's called exon 11, and it's the most common site. The second most common site is just outside of the tumor cell in an area called the extracellular juxtamembrane domain, or exon 9. And those are the two most common sites of KIT. There's another gene that we talk about called platelet-derived growth factor receptor, or PDGFR. So mutation happens in this gene. So how does that mutation lead to a cancer cell? And this cartoon is a functional cartoon showing, again, this is the plasma membrane that surrounds the tumor cell. This is outside of the tumor cell, and this is inside of the tumor cell. And these receptors' normal job is to carry information from outside of the cell into the cell. In the setting of a mutation, these proteins like KIT that are mutated are always turned on, just like a light switch is always turned on. And that light switch then sends a signal into the tumor cell's DNA and into the nucleus and tells that tumor cell to start that process of dividing from 1 into 2, 2 into 4, etc. But it also tells the tumor cell not to die. Cells dying is a normal cellular process. Your skin cells, they fall off and die all the time in a process that's regulated called apoptosis. Well, KIT mutation tells the GIST cells not to die, so they stay alive. And it also helps them invade into blood vessels and spread throughout the body. It also helps recruit new blood vessels into the tumor so that the tumor can enlarge. So KIT is a very, very nasty oncogene, and it seems to be sufficient to do all of these processes. So it's not surprising that companies like Ciba-Geigy, now Novartis, and other companies had been searching for drugs that could bind to these receptors and turn them off. And so the lead compound out of this process, imatinib, is a 2-phenylaminopyrimidine structure that was designed based on ATP to bind into a normal binding site in the receptor and turn that KIT gene off, turn the protein off, just like turning off a light switch. And that was the design, and it was modified to be water-soluble and orally available to be as a pill. And it was initially designed to target a number of these kinase receptors, such as PDGF, but also found to inhibit KIT and BCR-ABL in the leukemias. And so when imatinib binds to KIT, it changes the structure of the KIT protein such that the protein cannot send that signal. And this is turning off the light switch. Now the receptor is in the off position, and it's no longer able to send that signal into the nucleus and tell that tumor cell to do all of these bad things. So all of these processes get shut down. And with that information, a patient in Finland of Dr. Jansu had GI stromal tumor, had multiple surgeries, had multiple different chemotherapies, and really had no other options. And so she had sought his care, and he, based on the information you've seen so far, had thought that using imatinib in this situation had some rationale. There were no clinical trials, there were no cell line models, there was really no other rationale other than what we've discussed. And so he had this patient, and this is just a PET scan, and just to show you, a PET scan uses FDG, so it's a slight amount of radioactive glucose, a very, very small amount is injected into the patient, and tumor cells accumulate glucose as their food much more rapidly than normal cells in the body. And so FDG is made so that when it goes into the tumor cells, it gets stuck there. So these spots that you see that are dark gray or black in this area are tumor cells that are metabolically active because they're using that glucose rapidly, and they're growing, and they're doing all those bad things. Well, when the patient took Gleevec, she began feeling better within just a few days to weeks. And so Dr. Jansu repeated this PET scan, and you can see that this patient has now had all of those black spots go away. And that means that the tumor is no longer accumulating all that glucose. It's no longer dividing and proliferating and doing all of those bad things. And this correlated with the patient feeling better. And so when they, in this case, did a biopsy, they found that the tumor cells, and Dr. Wong will go over more of this later, but these blue spots are tumor cells within a mass. And you can see that it's highly compact, and there's lots of tumor cells present in the patient's tumor. And then just after 1 month of therapy, the majority of those cells go away. There are still a few cells left behind, but the majority have been treated by imatinib and have gone away and left behind this type of debris. So now I'm just going to, with that background, I'm going to go through some of the questions that I get when I see patients in clinic. And so when a patient comes to me with newly diagnosed GI stromal tumor, they might ask, what is the chance of imatinib helping me? And so we do have data now on this, and the chance is very good. And so this is a table that one of our other faculty who also sees a lot of GIST patients, Dr. Dejka Arujo, she put this table together a few years ago. And this represents the major clinical trials for patients with GIST that has spread, which we call metastatic. It has spread throughout their body. And so if you look at this red box at the top in yellow, you can see complete response, partial response, and stable disease. And that complete response means that the tumor has gone away completely and there's no evidence of it anywhere in the patient's body. Partial response means that it has shrunk significantly or decreased in size. And stable disease means it's kind of a mixed bag. It means that the patient's tumor is shrinking, but it hasn't shrank a whole lot, or it means the patient might be responding by a different criteria, or it could also mean that the patient's tumor has grown a hair, a little bit. So it's kind of a mixed bag. And then just to the right of that in yellow is PD, or progressive disease. And those are the patients from all of these studies whose tumors have clearly grown substantially. So the chance of a tumor stopping growing, the chance that a tumor is going to stop growing or decrease in size when a patient with GIST is treated with imatinib is really in the 85% range. And so I'll just discuss one of these largest studies, and this is the phase 3 study for patients with metastatic GIST treated with imatinib, and this is the North American study. An identical study was performed in Europe. And so what happened on this study is that patients with newly diagnosed GIST were treated with imatinib, and they were randomized by the flip of a coin to receive either 400 milligrams per day or 800 milligrams per day. If the patient's tumor started growing on 400 milligrams per day, then their dose was escalated to 800 milligrams per day. So this is how this clinical trial was set up. And the reason I'm introducing it is because it's given us some information on how to manage patients with GIST appropriately. First of all, it showed us how well imatinib works. So the green curve, again, this is a Kaplan-Meier, so the y-axis represents the probability of patients dying from their GIST, and the x-axis represents time. And so the 50% mark is that point in time at which half of the patients have succumbed to their disease. And in this database from Europe, it's only about 9 months. Now with the use of imatinib, in this publication, which was the first publication of these large trials, it's way out past 30 months. In fact, it's out at 5 years now. So how long do I take imatinib? That's another question that I get asked by patients in clinic, and is a reasonable question to ask. And we don't know the precise answer, but we do have some data that helps us give us some guidelines to that respect. So remember this patient, the very first patient treated with imatinib, her tumor was compact with all of these tumor cells. The blue represents the nuclei in the tumor cells, so it's very dense and a very cellular tumor. And then after imatinib therapy, you can see that the majority of the cells are gone. They're dead and gone, 99% probably. But you can also see that there are a few lingering behind. So yes, imatinib and other TKIs clearly kill GIST cells. They're dead and gone by apoptosis and probably other mechanisms. But you can also see that it's not 100%. There are some of these GIST cells that use survival mechanisms to evade imatinib. And even though it's a small number, there are a few left behind. And this is common when we look at GIST patients. So what's going to happen if the patient stops imatinib or another TKI? What's going to happen to these cells? Well, we know that patients treated on these big clinical trials with imatinib, when they are treated when they continue on imatinib, so a patient treated with metastatic GIST treated with imatinib, when they're imatinib stops working and their tumor starts growing, we know if they stay on imatinib and keep taking imatinib, in the North American study, their tumors don't grow for about 3 months on average. In about 3 months, their tumors will start growing even though they're still taking imatinib. Now, another study I'm going to discuss in more detail later, patients with metastatic GIST whose GIST started growing again on imatinib, stopped their imatinib and took a placebo. So this is a placebo study that was not done at my institution, but was done at several institutions around the world. And these patients with metastatic GIST on imatinib were randomized again by a flip of a coin, and half of the patients took a new drug on the orange curve, and half of the patients took a placebo. So you can see on the orange curve, and I'll talk about this more later, that sunitinib controlled their disease for over 6 months. So that's great news. But unfortunately, you can see on the lighter colored light blue curve, you can see that half of these patients' tumors started growing by about 6 weeks. So stopping imatinib in these two data sets suggests that it leads to acceleration of the tumor, although that's not been proven. That is something that is suggested by these two studies. Well, in France, they sought to answer the question a little differently. So in France, a study called BFR14 was performed, and this clinical trial took patients with metastatic GIST, and they treated all of these patients with imatinib, and patients did great. So they took the patients who had a great response to imatinib. They had tumor shrinking, or they had stable disease for 1 year, or they had a complete response. Tumor went away completely. So they took these patients who were doing great on imatinib and had taken it for 3 years. So they've been on imatinib for 3 years, and then they randomized these patients again by the flip of a coin. Half of the patients kept taking imatinib, and the other half of the patients stopped taking imatinib. So what happened? Well, if you look at the green curve on top, if you continue taking imatinib, there's a very low risk of the GIST to start growing again. However, those patients who discontinued or stopped their imatinib are represented on the orange curve, and that represents a very high risk for those patients to have recurrence of their tumor. In fact, the median was at about 6 months. By 6 months, half of the patient's tumor had started growing again if they stopped imatinib, whereas it's about 18 months or longer for patients who were taking, who continued their imatinib for a longer duration. So, in general, with all of these tyrosine kinase inhibitors, imatinib, sunitinib, all of these, my approach is to try to maintain patients on imatinib therapy with metastatic GIST. Just keep taking it every day. Now, patients might take a break from it, and taking a small break is, I don't advise it, but sometimes it's something that needs to be done for personal reasons, etc. And the small breaks are probably okay. But a long discontinuation puts patients at risk for their tumor growing again, and may, and again, this isn't proven, but may be selecting for resistance. And so I try to discourage that, but sometimes for personal reasons, it's necessary. The good news is that when patients on this study stopped taking their imatinib, when they were retreated with imatinib, they responded again. So we're able to gain control of their tumor in most cases. So generally and definitely, with all of these tyrosine kinase inhibitors, it's something that you just have to continue taking as chronic therapy. So there's another question. What dose of imatinib should I take? Well, it's been looked at in clinical trials of 400 versus 600. It's been looked at 400 versus 800. FDA has approved 400 or 800, but what's the right dose for the individual patient? Well, in the biggest studies, one of these big phase 3 studies, where half of the patients took 400 milligrams and half of the patients took 800 milligrams, the patients who took 800 milligrams had about a 4-month benefit, a 4-month longer interval before their tumor started growing again. So they went about 4 months longer than the patients who took the 400 milligram dose. So there was a 4-month increase in the time before the tumor started growing again. And so the question is, does this apply to all patients? Or is there a subset of patients who really should be treated at a higher dose as individuals? And so there's a lot of data on mutation testing, and Dr. Wong will discuss more about mutation testing later today. And the two most common types I mentioned are exon 11 and exon 9. And so this is data from one of those big studies where half of the patients got 400 milligrams and half of the patients were treated with 800 milligrams. And if the patients were treated with either 400 or 800 milligrams, it took about a little over 2 years before tumors started growing again. Now, if you look at the patients with exon 11 mutation, if they were treated with 400 milligrams, that represents the darker curve on this analysis. And if the patients were treated with 800 milligrams, that represents the lighter curve, or the dotted curve, on this analysis. And you can see that there may be a 1 or 2 month increase if a patient with exon 11 mutation takes 800 milligrams compared to 400 milligrams. So it's a very small difference. It may not even be a real difference. It may just be by chance because the statistical analysis did not show that this could be confirmed. So this is really a marginal improvement in any for a patient with exon 11 mutation to take 800 milligram dose. Now, if a patient just has KIT exon 9 mutation, and that patient is treated with 400 milligrams in this study out of Europe, it took about 4 months before half of the patient's tumors started growing again. On the other hand, if the patient was treated with 800 milligrams, you can see that it took about 20 months before the patient's tumor started growing again. And this has been confirmed now in a larger study of almost 1,600 patients, that there is a clear superiority that's statistically significant, meets all of the criteria for real acceptable data, that patients with KIT exon 9 mutation will have a longer interval before their tumor starts growing again if they're treated at 800 milligrams than if they're treated at 400 milligrams. My approach in my practice is not to be so fixated on 800 milligrams, but to really to look at the patient individually and to assess the patient to try to get them on the maximum dose that they can tolerate with an acceptable quality of life. Because 800 milligrams in a 300-pound individual is different than 800 milligrams in a 80-pound individual. So it doesn't make sense that we should just give everybody 800 milligrams across the board. We don't do that with hardly any type of chemotherapy in cancer. We often dose it based on weight or body surface area. So what I do in my GIST patients is that I try to identify the highest dose that that patient can tolerate when they have exon 9 mutation. So often it's 800 milligrams, but sometimes it's 600 milligrams. And I'm going to discuss this in a little bit later, but I don't start anybody at 800 milligrams. I start patients at 400 milligram dose or lower and slowly escalate their dose over time such that I can reach a target of 800 milligrams or the highest dose that they tolerate. Now this is data from the North American study, and in our study, an odds ratio was calculated, and this was presented at ASCO, showing that patients with exon 9 mutation were 8 times more likely to respond to to 800 milligrams than patients with exon 11 mutation. So I'm going to talk a little bit about side effects. I'm going to kind of keep it general and kind of give you a general overview. Pat Neal later is going to discuss side effects in more detail and their management, more importantly. So this is just a list of side effects that are common in patients with GIST when they're treated with imatinib. These side effects are also statistically more common in 800 milligram dosing than 400 milligram dosing. So 800 milligrams of imatinib has more side effects than 400 milligrams. Now, if you remember this study design, patients with metastatic GIST were treated with either 400 milligrams or 800 milligrams as their initial dose. So these patients, first day they took imatinib, they took 800 milligrams all together that day. Twice a day divided, but they took 800 milligrams that day as their first dose. Now, I don't do that clinically, but that's the way it was done in this study. And so, and this study was done a while back, so that's, the clinical management has evolved since then. And so these side effects, particularly edema, fatigue, anemia, are much more significant at 800 milligrams than at 400 milligrams. Now, is it important? Yes, it's important, because in this study, what they found was that when a patient is treated with 800 milligrams per day, their treatment had to be interrupted because of side effects 64% of the time. And their dose was reduced 60% of the time. So if one has a patient with exon 9 mutation and you're targeting 800 milligram as the dose, and 60% of the time you're going to have to reduce it, you're not really accomplishing what your goal was to do. So we needed an answer to this situation. And so what we looked at in the North American study was that crossover arm. So the crossover, remember, patients with metastatic GIST are taking 400 milligrams every day. If their tumor starts growing again, then they start taking 800 milligrams per day. So they've been on 400 for a while, and then they escalate to 800. And so in the North American study, patients that took imatinib 400 milligrams per day had to reduce their dose 10% of the time. If they took 800 milligrams that first day, they had to reduce their dose 44% of the time. If they took 400 milligrams for a while and then escalated to 800 milligrams, they had only to reduce their dose 16% of the time. And so this echoes what I see in my clinical practice. So I don't start anybody on 800 milligrams. In fact, sometimes I don't even start patients on 400 milligrams. I may start them on 200 milligrams, leave them on that for a couple of weeks, and then escalate to 400 milligrams. I had one patient who I had to start on 50 milligrams because she was thought to be intolerant to imatinib because they gave her 400 milligrams as her initial dose, and she had a lot of side effects. So I started her on 50 milligrams, and every 2 weeks we went up by 50 milligrams, and I got her up to 400 milligrams with almost no side effects at all. So there's something about working into it slowly, and I don't know the precise physiology, whether it's a chemical reaction to the GI tract or whether it is mediated by some of these receptors or targets that imatinib is hitting, but working into these drugs slowly is clearly beneficial to most patients. So how do I know if imatinib is working? Well, there's interesting data that came out from all of these clinical trials. This is the first phase 2 clinical trial, and partial responses, you can see that at 400 or 600 milligrams, what the investigators published was that about 38% of the time imatinib worked. Seemed like 62% of the time it didn't. And then the same study was looked at again later. So this is 9 or 12 months later. Same patients, same study, same investigators, and now they're saying that imatinib works 65% of the time, nearly 70% of the time. So why that discrepancy? Well, this is data was looked at from Europe, And what you can see here is that there is if you look from your left to your right, you can see that these curves gradually increase, eventually plateauing out at about 2 years, but still going up. And so this curve, again, is a Kaplan-Meier type curve, and it shows the incidence of partial responses on the y-axis and time on the x-axis. So it's essentially how long does it take to meet the criteria that were used in these clinical trials at the time. How long did it take for a patient's tumor to shrink enough to be called a responder? And so you can see that it takes a long time. In some patients, it takes 2 years for a tumor to shrink enough. Some patients' tumors shrink quickly at the beginning. Sometimes it takes a long time. So one has to be patient. And I'll just show you some examples. So I'm not a radiologist, and we don't have a radiology session this year, but I'm going to wing it. And so if you look at these CT scans, what you'll, just to orient you, pretend like this is a patient laying on the CT scan table, and this is the patient's back, and this is the patient's front, this is the patient's right, this is the patient's left, and so the patient's looking up, and this is a cross-section through the pelvis. So this is like the hip bone here and the pelvis, and this is the sacrum, and then this is the other side. And the patients, when CT scans are done, patients are injected with IV contrast. And so things that are white have IV contrast. Things that are white may have oral contrast or rectal contrast. Things that are white might be bone. Things that are black are air. So you can see the air is black on the CT scan. And this is just air in the GI tract. And then you can look at the tumor. This is a tumor. And you can see that it's kind of gray in between because it's taking up the IV contrast that was injected into the patient, into the tumor blood vessels. And so this tumor has markedly shrank in size in just a few months. So this is a great response to therapy. The tumor has shrank away. But sometimes we don't see that. If you look at this situation, this is another patient, and this tumor has not shrank a whole lot. It shrank some, but what you notice is that there's been a drastic change in the grayness of the tumor. And this is what we call enhancement or attenuation. So this tumor has decreased in size a little bit, but it's become much darker in its grayness. So even though this tumor would be called stable disease by the common clinical trial criteria that most places use, this is clearly a great response because the tumor is no longer taking up IV contrast. That's why it's darker in its grayness. So it's not that IV contrast that's injected into the patient never makes it into the tumor because the tumor blood vessels have died and gone away. There's no blood vessels in the tumor. And we know that this is true from biopsies and surgeries that patients have had, that this is nearly a complete response represented on this slide, even though the tumor has not shrank a whole lot. And common clinical trial criteria that we've been discussing today would call this stable disease. But clinically, biologically, pathology, this is a great response, partial response or nearly complete response. And so even though the tumor has not shrank, this patient is doing great and is going to do great for a long time. And so if you look at the clinical trial data, and this is just one of the other clinical trials, it showed that patients who have stable disease, in other words, not growing tumors, do just as well as patients whose tumors have shrank a fair amount. Just like those two examples I gave you, those patients both are going to do well for a long time. Now, there are some pitfalls in the radiology. And that's why I look at every single CT scan that's done on every single GIST patient that I see, because there are some pitfalls that one can fall into. If one has an experienced radiologist, then those pitfalls can be avoided, but radiologists, when they're under a lot of pressure to look at as many of these CT scans as they can, as quickly as they can. They don't know the patient, they don't know the drugs that we use, and they don't know the disease. So there are some pitfalls that radiologists and clinicians can fall into. And so this is an example, another CT scan, showing a GIST here in the abdomen. And then this patient was treated with imatinib, and the GIST got larger. A few more months, the GIST even got larger. Well, what you'll notice is that the bright enhancing light gray part of the tumor is actually getting smaller. See it here? And then way out here, it's even getting smaller. The darker part of the tumor is what's getting larger. Well, this patient ended up having surgery, and that part of the GIST that was getting smaller is where the GIST cells were. The part of the GIST, of the tumor that was getting larger, had blood in it from hemorrhage and was filled with debris from dead GIST cells. So there were no viable GIST cells in that part of the tumor. So this patient was actually having a great response to therapy. And this was also confirmed on PET imaging because the PET avid lesion goes away. And so if a radiology report says this tumor has increased in size, that would be false and the patient is progressing disease and you should switch therapy. That would be a false assumption in this case. So whether this patient was being treated with imatinib or sunitinib or any of the tyrosine kinase inhibitors, this is a good response to therapy. And here's another example that one of our radiologists, Hasan Choi, published. And so this information is out in the medical literature for the radiologist to look at. And you can see that this GIST has increased in size, but the PET response is great. Metabolic activity is shut down, and those tumor cells are not doing any of the bad things that they can do. So this is another example of a great response to therapy. So here's another pitfall, and this is a patient with GIST in the liver, and there's a lesion in the anterior liver, and as the patient goes on therapy, the lesion becomes more apparent. So you can see the lesion becoming more apparent. And that's because the tumor cells are dying, they're not supporting the blood vessels, and that IV contrast is not making it into the tumor, so it becomes darker. So this is a great response to therapy. Now, if you look in the posterior portion of the liver on January 12th, there are no lesions. But then over time, they become apparent. Well, that's just because the lesions in January, they were there. You just couldn't see them because they had the same grayness as the patient's normal liver. And so somebody who's looking at these CT scans could make the mistake of saying there are new lesions and that the patient is no longer responding to this therapy and it should be stopped. But in fact, the patient in this situation also is doing very well on therapy, and the therapy should be and was continued. So in our clinical trials that we do here at MD Anderson, we don't use those old criteria. We look at, which are called RECIST. They only look at the tumor size. And all three of those specific situations I showed you, if you were using these older criteria called RECIST, those patients would have been called progression and would have had to come off the trial and stop the therapy. The criteria that we use is a modified RECIST criteria designed by Hasan Choi, one of our radiologists, and we look at a 10% decrease in size to term a patient a responder, or a decrease in that grayness. So if the tumor gets darker by 15%, and we can quantitate it to 1/10 of a decimal point. And so we use those criteria in our clinical trials for patients, and we get identical results as one gets with PET scan, and it's far superior than what you get with RECIST. You saw RECIST, just looking at size changes in the tumor, it can take 2 years before you know what's happening to the patient. With our criteria, you know in the first 2 to 4 months. So how do I know if my GIST comes back? So this is just a cartoon showing a liver of a patient, and you can imagine several GISTs in the liver. So when the patient is treated with imatinib or sunitinib or any of these TKIs, when they work, the tumors become darker, the blood vessels go away, and often you're left with these lesions in the liver that are essentially full of necrotic dead tumor cells. But resistance may happen over time. When resistance occurs, the resistance can take different forms. So there can be a form called limited progression, where there's only one lesion that's growing. There can be a form that's called nodular progression, where there's a nodule at the rim of a previously treated tumor that's growing. Or there can be widespread progression, where there are tumors growing everywhere in the patient's body at the same time. So this is one example. And so this is a patient, and there are multiple spots in the liver. And I'm just going to draw your attention to this one with the yellow arrow. Over time, this one by the yellow arrow has increased in size. Everything else in the liver is still being treated by the drug that the patient's on. So whatever drug they're on is controlling most of their disease, except there's this one spot that's growing. Here's another example of limited progression. There's this one spot that's growing. Often this is due to so-called secondary mutations, and Dr. Wong is going to discuss this more later today. And these mutations make resistance to some of these tyrosine kinase inhibitor. So now another question I get is, should I take imatinib after my GIST has been removed? And so I fall back on the largest data set to help me make this decision. And again, this is just a guideline to help me make the decision. I use my clinical judgment. I discuss it with the patient and take into consideration their individual perception of their disease and their expectations of their disease and their disease management. This is a very busy table, but I'll just say that we use this clinically. A lot of people use it clinically, and we look at the site of the primary tumor, the size of the primary tumor, and what the mitotic rate is. Mitotic rate, Dr. Wong will discuss also, is a surrogate for how fast the tumor cells are dividing. So if there's a high mitotic rate, then there's a higher risk of a patient's GIST coming back. If the GIST is arising in the small intestine, there's a higher risk for the GIST coming back. If the tumor is larger, there's a higher risk for the tumor coming back. So those are the factors that I take into consideration. And there's actually some data to support this. So the data come in the form of a clinical trial performed by the American College of Surgical Oncology. And this was a randomized study where patients with their primary GIST had it removed, and they were randomized to either 1 year of Gleevec 400 milligrams per day or placebo for 1 year. And so the data from the trial at 1 year, if a patient has their GIST removed, they take Gleevec for 1 year, or they take placebo for 1 year. If they took Gleevec for 1 year, they only had a 2% chance of their GIST coming back at 1 year. Okay, this is all patients with a tumor greater than 3 centimeters. If they took placebo for 1 year, they had an 18% chance of their GIST coming back. So there's a substantially higher risk for GIST coming back if the patient was not treated in this study. Now, if you look at subgroups, certainly the larger patients with larger tumors are at higher risk for their GIST coming back and higher mitotic rate as well. But what you also note on this analysis is that in the patients who took GIST, they seem to have a very flat curve and very low risk of recurrence out to about 18 months, and then the curve starts going down and the number of recurrences starts picking up after 1 year. And it's roughly parallel to the patients who didn't take Gleevec at all. So what we looked at here at MD Anderson was we looked at a 2-year study. So patients had their GIST taken out, and then they took Gleevec for 2 years compared to 1 year. And I have to caution you, you cannot compare these two studies because they're directly and do any type of statistical analysis because they're different studies. and they're different patients and different data sets, so you can't make direct comparisons, but you can do some inferring. And so if you look at 2 years on the right side of the curve, at 2 years, the recurrence rate of the patients on imatinib was about 91% on Z9001. If you look at the placebo, it was only 71%. In our study, it was 87%. So they're roughly the same at 2 years for taking Gleevec for 1 year or taking Gleevec for 2 years. However, I have to tell you, since our study is a single institution study, we were able to go back and look at every single patient who took Gleevec on this study. And so when we did that, and when we excluded patients who stopped Gleevec after 6 months, some patients stopped Gleevec after 3 months, and we only included, and they did this for a variety of reasons, transportation problems, financial problems, family problems. So when we only looked at the patients who took 2 years of Gleevec after their surgery, what we found is that not a single patient had their GIST come back or start growing again during that 2-year period. And it's not an intent to treat analysis. It's a somewhat flawed analysis because of biases and problems like that. But it's pretty compelling to me as a clinician when I see that my patients on Gleevec, not a single one of them had their GIST come back while they were on it. So that data has led to other studies. So the other studies that are going on right now in the Scandinavian group, they're looking at patients who had their GIST taken out, no GIST anywhere else in their body. They're taking Gleevec for 1 year or they're taking Gleevec for 3 years. There's an EORTC European study looking at none versus 2 years. Or there's a phase 2 study that we're doing here at MD Anderson and at a number of other sites throughout the US looking at 5 years of imatinib after their GIST was taken out, particularly for those high-risk patients who have a high risk of their GIST coming back. This is a very good study. And so I'm just going to end by a question I get, will my kids get GIST? Young people do get GIST. Dr. Kim is here with us today and is going to discuss his clinic at NIH for pediatric and wild-type GIST. But young people do get GIST, and they ask me about the likelihood of passing it on to their kids. And in actuality, it's extremely rare. The chance of having a hereditary GIST that's going to be passed from parent to child, that mutation has to be in every single cell of the affected individual's body at the DNA level. And the chance of that happening is so rare, there's only about 20 cases reported throughout the world. So 5 or 6 billion people, there's only about 20 cases. There's only 2 known families in the United States, in the entire United States, where there's been any evidence of passing GIST on to their children in this setting of a KIT mutation that's mutated in the germline in every single cell of their body. There are some other situations where there might be a risk of GIST that is passed on to an individual's offspring, but the situation where it's definitely passed on is pretty rare. And so this is a family that I see from the southeastern United States who has about 18 cases of GIST 15 cases of GIST in their family. And it's usually pretty apparent. So I don't mean to gross you guys out right after breakfast, but it's very apparent when I talk to a patient, if they tell me that there are 14 other people in their family with GIST, then that tells me that there's something going on in passing it down from parent to offspring. So this is an extremely rare situation, and it's incredibly apparent when it happens. So I ask my patients, are there any other GIST cases in your family? And they give me their family history, and there may be other cancers, but almost always there are no other GIST cases in their family. So it's the situation where it's very apparent when it does happen. So I'm going to end this portion of the GIST and open the platform up for any questions, and I'd really like to thank you guys for your attention. Any questions? Oh, microphones. We need the people. Yeah, well, we're getting you a microphone. Right here, in the green scarf here. Oh, okay.
I'm not the one.
Thank you, Doctor. This is fabulous education and an honor to be here. My daughter's newly diagnosed. I know some of her information was passed on to you down here, but the question that I have is that she's negative for exon 9, 11, 13, and 17, and I just wondered if that still made her applicable for Gleevec. She doesn't have any other genetic testing.
From my experience, if the patient should be treated and there's an indication to treat, even if they are wild type, I usually, in most situations, try Gleevec. I don't exclude it as being ineffective because I do have some patients who don't have any of these mutations that we test for that do respond strikingly well and get years and years of benefit from imatinib. And that's probably because there are some occult mutations that we're not testing for that just happen to show that are so rare we don't test for them. And maybe Dr. Kim will discuss this in more detail later, but I wouldn't throw imatinib or sunitinib or any of them out the window and say they're not going to work, because they have before.
Thank you very much.
Any other questions?
My name's Robin. I wanted to know if my insurance wouldn't pay for the exon testing. I mean, you obviously do it here every time. So I had been through the Gleevec and everything, but would you recommend, like, newly diagnosed, even if your insurance won't pay for it, to get exon testing?
That's a little bit of an individualized decision. And we do run into that situation maybe only about 10 or 20% of the time. 80 or 90% of the time, in our experience, the insurance companies will pay for it. And sometimes I have to write letters. Sometimes I have to call insurance to talk to the physician representative at the insurance company. But we can usually get it most of the time. When you can't get it, then your options are somewhat limited. There are some people who are willing to pay out of pocket for it, but I think it can probably cost probably nearly $1,000 maybe.
Yeah, well, I'm past the Gleevec anyway,
Yeah.
but so I don't know, I'm much further along now, so I don't know if after a while
Yeah.
it matters.
But for me, in my practice, it's clinically relevant, so I do everything I can to get that information ahead of time. And also, it's the only way to know whether somebody has wild type. If you suspect wild type, the only way to prove it really is to do the mutation testing. And so, so I think it's clinically important, and I think it's it's sad that the insurance companies are not paying for it when we think, when the clinicians find it clinically useful.
Dr. Trent, out here in front.
Where? Oh, yeah.
I believe you said the data in the 90s before Gleevec was about 1 year survival rate. I missed, I guess, what the latest data is on survival rate on Gleevec as opposed to the 1 year.
Yeah, it's out past five. It's around 5 years. Yeah.
Dr. Trent,
Yep.
I am an exon 9. I've started taking Gleevec in April, and now I'm up to 800. Do you think I should go back to my doctor and question this? Because I keep having all these side effects.
Yeah, I think if your side effects are really, and my approach, and Pat Neal will discuss her approach a little later, is we treat the side effects very aggressively. There are some side effects that you can manage, but there's some side effects that we really don't do a very good job managing, such as fatigue. That can be one of the hardest side effects to manage. There are some things that we do to try to help with fatigue, but that's really one of the hardest ones to manage. So
I've had this rash for like 3-4 months. Can't get rid of it. Just keeps breaking out. Kind of goes away. What else? And the edema's getting worse. So do you think I should just go back and say maybe we should start again, or?
you know, it might be a situation where you go down to 600 milligrams for a while, get used to that, and then maybe in a few months try going back up. You know, and work with your doctor to manage your side effects as best as you can.
Stay on 800, actually?
I don't, you know, it's a very personalized and individual decision.
Okay.
And it's the kind of situation where we can maybe talk about it in person after this. But it has to do with your quality of life. And if you're miserable and not enjoying your life at all,
Well, they say,
then,
are you happy? And it's like, do you feel good? And it's like,
yeah,
I don't know what a good day feels like. So,
so.
okay, thank you.
Yeah.
How are you treating the extreme fatigue?
Also, sometimes we try a low dose of Synthroid, which is thyroid replacement, which is your body's hormone to increase metabolism. Sometimes we try a drug called Ritalin, which is a stimulant. And then there are some other drugs that are coming in the pipeline. We have a fatigue clinic here at MD Anderson for cancer patients who have fatigue because it's such a big problem. And they have some new agents that they're using that I've just started trying and had some good results with. We've used on a couple of occasions a low dose of steroid, dexamethasone, a very low dose of steroid, and I've seen striking improvement in fatigue with that one in a couple of patients. So there are some things to try, but it is very hard to manage. Yeah.
Do you feel there's any benefit to dividing the dose through the day? Is there any clinical pharmacology reason why you can't do that?
No, it's perfect. I recommend dividing it twice a day for 800 or 600, and there's some patients who do much better with 400 if they divide it twice a day. And the pharmacology is perfectly fine to divide it twice a day than taking it once a day. And in fact, you'll get a lower peak. The peak level will be lower, so it may be favorable to divide it twice a day. Yeah.
Yes. I wanted to ask you, okay, where am I? The mitotic rate of mine is 22 per 10 high power fields, and then at the bottom it says K1-67, 25 to 30% unfavorable. I don't know what that means, and also, what does that have
Is that
to do
your
with-
pathology report?
Yes.
Maybe we should talk about that after.
Okay.
Okay.
Thank you.
Yeah.
Doctor, we know this is classified as a rare cancer, and we hear the number 5,000 in the U.S. every year. I assume that's the number of patients that are classified having the GIST condition. Can you kind of put a face on that for us? Is there any estimate of the demographics of GIST, meaning worldwide? Is there ever been a situation where they've tried to look at the enormity of this thing on a worldwide basis?
Not specifically globally. There are a couple of registries that are registering thousands of patients to gather their data, not in any type of interventional way, but just to gather their data and look at the demographics of the patients. And those registries will be publishing their data soon. But having looked at it and seen some of the presentations, it's fairly common across all ethnic and racial groups. So I don't think, I mean, I think it's pretty widespread and fairly evenly distributed, but that information will be coming out, I think, in the next couple of years. Yeah.
Good morning, Dr. Trent. Could you address any funding for research that's on a nationwide basis, or is there anything that's done to investigate this disease?
Yeah, there are some there are some groups. There are some groups in the United States that raise money for just research. There are some certainly NIH grants that are available, and certainly a GIST research could be funded through the National Institute of Health. The problem with funding through the government is that the government views this as a very rare disease, and when they have to distribute their money, they're in general, from what I've seen, tend to fund the more common cancers, breast cancer, colon cancer. So it's very hard for us, just researchers, to get funding for just research from the government. So we have been lucky to have help from organizations, and to be frank, from individuals, philanthropy from individuals. Here at MD Anderson has helped our GIST research tremendously and allowed us to assign researchers in the laboratories and in the clinic to focus on GIST only. So even individual philanthropy has been very helpful for us. So it comes from whatever source we can get research funding, whether I've been able to get some from the government, some from groups and foundations, and some from individuals who, out of the goodness of their heart, have donated to research. Yeah. Yeah. Okay.
Dr. Trent, my question is on fatigue. What is considered chronic fatigue? I've heard it mentioned a couple of different times.
Yeah.
How do we define it we're a problem?
Yeah, I think it has, there are specific definitions that apply to it as to what percentage of time you're spending sitting in a chair doing nothing versus up around mowing your yard and carrying out your activities of daily living. And there are specific definitions. I'm just not that familiar with them. And the way I approach it is, if the patient tells me it's a problem, then it's a problem and we need to address it. But it's very subjective and hard to define. Now, I think we may have to move on in the interest of time. One more question?
Yes, just a real simple question. About how many GIST patients are handled by your group?
We see I think about 250 a year. I see probably 150 to 200 of those. Okay.